Okay, well, I think we can get started this evening. I'm Dr. Michael Moore, the Director of Continuing Medical Education at Sovah Health, and along with Vinay Mayo, the CME Coordinator for Sovah, we welcome you to this program this evening on inflammatory bowel disease. The program this evening provides 1 hour of Category 1 physician AMA CME credit and 1 hour of Virginia Nurses Association CE credit. Sova Health is accredited by the Southern States Collaborative to provide Category 1 CME credit for physicians. Similarly, Sova Health is accredited by the American Nurses Credentialing Center's Commission on Accreditation for Nursing CE credit. The program was developed to promote two desirable physician attributes, providing patient-centered care and our employing evidence-based medicine. This topic was identified as part of the Sova Health's annual medical staff needs assessment for educational gaps that we can address with CME programming. Dr. Wong, our speaker this evening, myself, and members of the Sova Health CME committee have no commercial relationships to report to you this evening. And similarly, there is no commercial support for this educational activity. The program is supported by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the local urology nephrology practice a number of years ago, made a sizable donation to create this endowment for a medical education for all types of healthcare professionals in our community. And we're very grateful for Ralph's forward thinking and interest in making this available to the programs that are provided. You will receive two ways to get at the evaluation form. We like to evaluate all of our CME programs as to effectiveness and content. Vinay will put a QR code in the chat box at the end of the program. She'll also put an internet link you can click on. Either one will take you to the form. The form has some 7 questions. We always remind you to look at question number 4. It asks you what changes will you be making in your practice based on what you learned this evening. And that question's for everybody, not just the providers. We all practice our skills based on our scope of practice. Take a few minutes and complete the form, and there's instructions about sending it along back to us. I will remind you that on that eval form, you're asked to re-enter your name and your email contact. Please give us your full name, no nicknames, short names, cute names, because the name you place there is the name that will be on your CME certificate. I also need to remind the nurses and nurse practitioners on the call that your accreditation guidelines require you to complete an evaluation form in order to receive the CE credit. For our residents, and we have a number of our new residents on the program this evening, of which I am very, very much appreciative, and I welcome you again to Sova Health. You do not have to keep up with the CME certificates that you will be receiving from us. Your coordinator keeps up with your participation and the programs you've attended throughout the academic year. I always like to thank Vinay personally and Connie Plaster, who leads as the lead point for nursing education accreditation. My thanks to them for helping put the program together. They actually do all the heavy lifting behind the scenes that makes this actual event occur. So many, many thanks to them. Likewise, if you have any questions about your certificate, the eval forms, or anything about the program, I'll reach out to one of the 3 of us and we'll be glad to help you. I know Dr. Wong encourages questions, comments, discussion. If you will, put it in the chat, or at least the fact that you have a question. Vinay will be monitoring that for her, and she'll feed those to Dr. Wong as she answers the questions or they pop up. Let me ask you also, if you're doing a verbal question, which you're welcome to do, or make a comment, once you finish talking, please mute your phone so we don't get feedback. You can certainly come back and talk again as many times as you like. I also want to remind everybody, please, 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 just like in the movie theater, mute your phone so we don't have background knowledge. I'll highlight for you a couple of upcoming programs. In about 2 weeks, on Thursday night, August 13th, Dr. Nicholas Turner, an infectious disease physician at Duke, will be talking about tuberculosis. For those of you that are my age, and there's not many on the call that are my age, we actually grew up with TB and had rotations in our training and what were then tuberculosis sanatoriums. But over the past 30 or 40 years, TB was originally thought to have been eradicated in the US, but over the past 2 or 3 years, it's actually coming back. So Dr. Turner is an expert in tuberculosis. He'll be helping us all get refreshed in how it presents and how you treat it. And then the other program in August is one I'm just delighted we're going to be able to have. The American Heart Association this year has put out new guidelines for management of high blood pressure, lipids, and stroke, acute strokes. And so that we've already had the high blood pressure program presented, the update by Dr. Dan Jones from the University of Mississippi. Dr. Roger Blumenthal is the director of the Center for Prevention of Cardiovascular Disease at Hopkins. He chairs the new guidelines from the American Heart, American College of Cardiology, and other professional groups about how lipids should be managed. And so I hope you'll plan to be with us on the evening of August 27th. I didn't make a slide to this tonight, but later in the year in September, we'll have Dr. Al Husseini from Duke who will be reviewing the new American Heart Stroke guidelines. Well, that leads us to the program this evening. And Dr. Wong, you can bring up your slides as I tell them about your wonderful career. Dr. Wong is a native of Richmond, Virginia. So she's a Virginia physician by birth and being raised. She finished in her undergraduate degree at William and Mary. And there she graduated summa cum laude and Phi Beta Kappa, a Bachelor of Science in Chemistry. If you're into collegiate world, the BS is really a major undertaking. We have someone that needs to mute their phone. Someone needs to mute their phone, okay? Following William and Mary, she received her MD degree from Cornell, where she not only was a member of the AOA Honor Society for Academic Excellence, she was its president. She then completed her IM residency at the University of Pennsylvania, where she, among other things, began an art club for the residents when in faculty, which I thought was really renaissance young lady at that point. That followed GI fellowships at Duke, and as she had been in all of her other academic endeavors, she was awarded the best GI Grand Rounds as a fellow, which was a significant honor there. She remained on faculty at Duke, where she is currently in the Department of GI, and we're just so happy to have her. She has numerous peer-reviewed, high-impact publications and presentations and a large teaching role at Duke. So Dr. Wong, I'm delighted you're with us. I hope everyone can see your slides, and it's all yours. Thank you so much.
Thank you so much for that kind introduction, Dr. Moore. And thank you so much for all of you for being here with us tonight. I am really excited to talk to you about inflammatory bowel disease. I know that y'all have very large scopes of practice, and there are many things we could talk about inflammatory bowel disease, but we're going to focus on diagnosis and management, specifically through the lens of primary care and being on the front lines for diagnosis. Duke GI is a large GI group, and we have the privilege of being able to super specialize in very small niches within medicine. So I actually primarily spend my time doing inflammatory bowel disease work in my clinic. So a lot of patients who are getting their initial diagnoses with you or in your community may end up seeing me or one of my colleagues down the line. And we know it's a complex disease process, want to be helpful. Our learning objectives today are to improve competency and diagnosis and initial management of inflammatory bowel disease. And this objective encompasses 4 main points. One is I want to focus on the common initial symptoms of Crohn's disease and ulcerative colitis. We will go over how people typically present, and then we'll also kind of dig into why people present in different ways so that it's easier to remember why someone may be feeling something. Secondly, we will go over how to diagnose IBD, what is inflammatory bowel disease, and what do you need to make a diagnosis. And then after that, we'll jump into initial therapies, what the role of an initial therapy is, what their limitations are. And then finally, we will talk about how do we anticipate needs for patients with established inflammatory bowel disease diagnoses. Because this is a chronic disease, they are going to have ongoing needs. And we, as GI IBD docs, partner super closely with the primary care world to make sure they continue staying well. So, part one, what is inflammatory bowel disease? I am going to specifically try to say inflammatory bowel disease because the people who made alphabet soup acronyms did not help us remember exactly what these were. So, inflammatory bowel disease is an immune-mediated intestine inflammation. It is classically thought of as an autoimmune disorder, but the way that I like to think about it, and the way I think it makes more sense, is to think about it as a confused immune system, as opposed to a malicious immune system. There are two main types of inflammatory bowel disease, which we'll go into: Crohn's disease and ulcerative colitis. It's just helpful to know that they fall under this inflammatory bowel disease bucket because they share some pathophysiology, they share a lot of treatments, and they sometimes can mimic each other or even overlap. You may see people who carry something called indeterminate colitis, which basically means we're not sure if it's Crohn's or ulcerative colitis, but it's acting like one of them. The treatments for inflammatory bowel disease are medication and surgery. I'll be focusing on the medication side of things, but patients may come to you with questions or fears about surgery. I think it's always right to acknowledge our toolbox is deep in inflammatory bowel disease. That's good. We just have to figure out which therapy, which tool makes the most sense for which person at which time. So, how is inflammation confused in ulcerative colitis and Crohn's disease? Well, inflammation is good. It fights bacteria, it fights viruses. We want it to kick out precancer. Its job is to turn on in the body when there's an enemy and then turn off when there's not an enemy. The pathophysiology of inflammatory bowel disease is that for some reason, inflammation has turned on in the GI tract and it does not know how to turn itself off. We'll see that this inflammation that has turned on in the GI system and stays on can cause ongoing inflammation and therefore damage and a lot of symptom burden, morbidity, even mortality. It is an incurable chronic condition. So once present, that inflammation on its own, in the vast, vast majority of people, it's not going to magically turn itself off. People may feel better because it may wax and wane, but we know that the majority of people who have Crohn's disease and ulcerative colitis will continue to have inflammation unless they go on therapy. That being said, it's incurable, but we do have treatments, and our treatments are getting better and better. So our job as GI doctors is to find a medication that takes that inflammation, turns it off, keeps it off long enough for that area to heal, because inflammation damage is going to take time to heal, and then keeps it off so that no ongoing damage happens. The goal of inflammatory bowel disease treatment is remission, where there is no active inflammation. So in remission, that includes clinical remission. People feel back to normal. Biochemical remission. They're not having sequelae of inflammation anymore. And endoscopic remission, where you put a camera in their colon and the abnormal picture you see over on the right goes from super abnormal to the bottom one where it looks like you would never know that it had inflammatory bowel disease. That's the dream. It's not a dream that always happens fast, and if people do have active inflammation from their inflammatory bowel disease, they often refer to it as flares or flaring. But I want to change the narrative in that when people have inflammatory bowel disease under good control, they should not be flaring. So it's not an assumption that they will flare for the rest of their life. Flaring simply means there's inflammatory bowel disease that's active that we don't have the right medications or control over. We care about active inflammation because it makes people feel crummy, and also because the more damage that happens, the more scar tissue, the more changes, the more complications, the more damage. Okay, I had to put this slide very early because it confuses the best of us. I tell my patients that whoever named IBD and IBS needs to be like punished or chastised or put in timeout because they sound way too similar and they are very, very different. We are going to focus on IBD, inflammatory bowel disease. So the way I remember it is disease, well, the D in IBD stands for disease, but D disease, think damage. So it is a destructive autoimmune inflammation. There is damage happening, scar tissue building, infectious risks to all of this. And when you go to examine the GI tract and look for inflammation, you find inflammation and damage. Importantly, inflammatory bowel disease, IBD, where there's damage, increases risk for colon cancer. On the other side of the screen is irritable bowel syndrome. We are not going to focus on this today. It is a very real syndrome and GI condition in its own right and has high symptom burden, but that is the key. IBS, or irritable bowel syndrome, think syndrome symptoms. These patients can have very significant symptoms, but their symptoms don't involve damage or inflammation to the GI system. It is a brain-gut disorder, which means that the nerves talking to the GI system have mixed communication and are sending signals that are inappropriate that cause symptoms. There's no inflammation, there's no damage. If you put a scope into this person, you're not going to see abnormality or inflammation, and it doesn't cause long-term damage. You cannot have an increased risk of colon cancer because of irritable bowel syndrome, or IBS. No increased risk of colon cancer and no increased risk of inflammatory bowel disease. See, I got caught up on the alphabet soup. So IBS, syndrome, symptoms, not damage. IBD, what we're talking about today, inflammatory bowel disease, which true damage, morbidity, mortality. Okay, now that we have established we're working with D and not S, inflammatory bowel disease encompasses ulcerative colitis and Crohn's disease. Again, they have a lot of similarities, but we'll go in a little bit to the differences, mostly because I think it helps us think through how these patients can present. I tried to label all the slides about ulcerative colitis with this yellowish color. So going over to the left side of the screen, ulcerative colitis is autoimmune inflammation of the mucosa of the colon. So I think it really helps to think about the colon as a really thick PVC pipe, where in ulcerative colitis, it's like the inflammation or the red paint is only involving the inside of the PVC pipe. The rest of the pipe is pretty normal. Doesn't mean that there aren't symptoms. That lining is real important, but it's affecting the lining, and it's, as the name says, colitis just in the colon. This means that we can approach it in certain ways. For example, ulcerative colitis can be surgically cured by taking the colon out. People usually want to keep their colons. We have medications to help them with that, but it only affects the colon. Because of the location that it affects, the lining of the colon, most patients are going to present with hematochezia and diarrhea. And interestingly, most people, if their colons are having inflammation and there's inflammation there, they usually have symptoms. So bad inflammation, bad symptoms, improved inflammation, improved symptoms. On the other side of things, we have Crohn's disease, which is going to be given this bluish color. Crohn's disease is an autoimmune disease of the GI tract, but it involves full thickness inflammation. So that entire PVC pipe from the inside through the thickness of the wall through to the outside has inflammation. And that changes the way it can show up in people and the damage it can do. It also can anatomically involve more places. So anywhere from mouth to anus can be affected by Crohn's disease. This means that there's a wide range of symptoms that can be associated with it. And then interestingly, this I know feels a little counterintuitive because of how many ways it can show up, but you will encounter patients who have horrible Crohn's disease inflammation. We know it, we see it on the imaging, we see it on their scopes, and they feel okay. Just because they feel okay doesn't mean the inflammation can't harm them. So remember, Crohn's disease, yes, they're feeling well, but let's make sure that their insides look as good as they feel. Last thing as we kind of go into this inflammatory bowel disease, how's it showing up? Remember age. So classically, we think about inflammatory bowel disease for young adults. So teens to 30s, kind of college age, late high school, early career. That is true. Most new diagnosis happens in young adulthood, about equally for males and females. But important, there is a second bimodal spike of new diagnosis for people in their late 50s to 60s. So more commonly, people are going to show up with ulcerative colitis at that age. But just to remember, inflammatory bowel disease can show up in someone who is trying to set up their retirement. This classically happens. I meet people in clinic, they're like, I was about to retire, or I just retired, or I was feeling great. I was planning trips around the world, and all of a sudden I'm bleeding out of my bottom. So think about that when you think about the patient who's walking into your clinic. Yes, most are young adults, but it can happen even later in life. Okay, summarizing what inflammatory bowel disease is. It's an immune-mediated disease of the GI tract. We've got ulcerative colitis for the lining of the colon, Crohn's disease for full thickness of anywhere in the GI tract. IBD and IBS are different. We're going to focus on IBD for damage. And it is a chronic disease. It does require lifelong treatment to control inflammation. And then that final point about age, young adults, but also adults who are trying to retire. Before we jump into the next section, I want to do a little intermission because one of the reasons why we and the world are thinking about IBD is because all of the meds that have ad time on television. There are so many of them. Um, this talk is not going to focus on the meds or the names or the 20 other generic names that exist. My take home for these meds are, as primary care providers, I do think that it is really important and helpful for you to recognize inflammatory bowel disease meds and be aware that they impact the immune system, because that can help connect things to the bigger picture that patients may need help connecting. But beyond recognizing that a lot of these MAB, IB, immune medications are related to inflammatory bowel disease, it is not your job to figure out which one's the best for which patient and to talk them through the risks and benefits and tell them, that they should change their medication or not change their medication. I think recognizing them is really the crux. And on that note, I also recognize they go by 20 million thousand names. So the take home is recognize the medications and go by their molecule name. So over on the right, purposefully small, all of the generic names or the originator names of these biologic molecules that are being produced by many different companies. Adalimumab, infliximab, guselkumab, risankizumab, it's all alphabet soup. Patients can't say these names. Some GI doctors can't say these names. MAB and IB can sometimes clue you off, but just try to block out the fancy, uh, dancing monster thing that's purple and I don't know, has a specific name. Focus on the scientific name. Do not be afraid to Google what the patient is calling their medication in order to figure out what they're talking about, because they can't say these meds either, and they will call them by their brand names, and everything has not just one, but several brand names now. So, bottom line, recognize they change the immune system and don't be afraid to look up what molecule they're actually talking about. Um, at the bottom, I just acknowledge, again, it's the GI's doctor to find the med with the best fit and to answer questions about how to manage these medications, especially in situations where they need to be paused. Because there are nuances, and there's no way that anyone can expect someone with such a broad scope of practice and knowing so many different organ systems to know the nuances of how to stop and start these meds. The person who's prescribing it should be the one to answer. Okay, now that we've established nobody can pronounce any of the IBD medications, let's go on to recognizing inflammatory bowel disease in someone who doesn't have a diagnosis. I am going to start with ulcerative colitis because it is fairly straightforward and it feels like the classic presentation. Ulcerative colitis in 90% of people presents with hematochezia, so bright red blood per rectum. In 90% of more people, they will have bleeding of some sort. This makes sense based on what we know about where ulcerative colitis forms. Ulcerative colitis starts in the rectum and then moves proximally towards the sigmoid, up the descending, maybe the transverse, and can even be pancolonic, including the ascending. But we know it's confluent and it starts in the rectum. So 100% of people who have ulcerative colitis, 100% will have their distal rectum involved, which means when poop comes out of their bottom, it passes an extremely inflamed, irritated area and it will drag blood with it. So blood at the exit, blood in the inflammation in the rectum, you've got your hematochezia. Most patients will also present with diarrhea. There's a reason this is our classic presentation. That's because everything in the colon except for the rectum is in charge of absorbing water out of the stool. So if that area is inflamed and not doing its job and not absorbing water and instead leaking inflammatory juice, you're going to have diarrhea with it. Diarrhea, frequency, and hematochezia, classic constellation, and many people will have that classic constellation. In terms of pain, people with ulcerative colitis can present with pain. They can present with rectal pain, again, because the rectum is very commonly involved. And oftentimes, just statistically, they will present with left-sided pain because the sigmoid kind of swoops around the left lower quadrant. And when that part squeezes because it's spasming and it's inflamed or it's trying to squeeze inflammatory juice out, it will cause cramping pain in the left lower quadrant. Not everybody has it there. Oftentimes it will be on both sides, but if someone's talking about left-sided, left lower quadrant pain, remember the sigmoid is there. It can absolutely be the culprit. Okay, I had a lot of fun naming this slide. The rectum is special. And the rectum is special for many reasons. One of those reasons is because it is the exit. It is the front porch to the outside world. It tells the body, there is stool here, there's stool here, and you need to let it out. So it's basically like a doorbell. But when it's inflamed, the doorbell is broken. And the doorbell cannot talk to the rest of the body and give it accurate information. So these patients have urgency symptoms. The doorbell is constantly going off. They can't stop it. They have tenesmus. The doorbell rings. You try to go to the bathroom. You can't get everything out. Sensation of incomplete evacuation. Also, the rectum does not have the job of absorbing water in the same way as the rest of the colon. So if patients only have ulcerative colitis in their rectum, they can present with constipation. So if other things smell like inflammatory bowel disease, right age, right timeline, blood in the stool, but they're constipated, don't write them off just because they don't have diarrhea. Remember, ulcerative colitis in the rectum, also known as ulcerative proctitis, can just show up with constipation. Okay, don't get me wrong, ulcerative colitis is interesting, but Crohn's disease can involve more anatomic areas and is full thickness. So lining, so mucosa, submucosa, and muscularis. So yes, some will have colon symptoms, especially if only their colon is involved. They can have diarrhea, rectal symptoms, bleeding. But there are so many other things that Crohn's can do. We're going to go over them. Pain, I think, is for this slide, my take home is Crohn's can do many things, including pain. And it's intuitive if we think about the fact that the entire PVC pipe has inflammation, because this ulcerative colitis thing, it's, yeah, the lining's inflamed, but it's bouncing up against the rest of the abdominal organs, and the stuff that's touching its neighbors is totally fine. In Crohn's disease, you have this angry, inflamed colon with angry exterior hitting other parts of the intestine, other parts of the abdomen, and of course, it's going to generate pain. So patients with Crohn's disease can present with pain that is seems more distinct than just bowel movement related pain. And uh, if you remember where Crohn's involves, it makes a little bit more sense. Other things it can do, small bowel, perianal disease, strictures, fistulas, we're going to talk about. So first, let's talk about the small intestine and why anatomy matters and how people will present. Over here on the right, I've got a floating pie chart. It tells you where Crohn's disease is commonly involved. This diagram over here circles the cecum and the small intestine, which is it's the hot spot for Crohn's disease. So about a third of patients will have Crohn's only in their colon, nothing in their small intestine. About a third will just have their ileum, so that last portion of the small intestine that hooks into the colon. Their ileum will be involved, but the colon, it doesn't have any issues. And then a third of patients are, that right lower quadrant hotspot, both their colon and their ileum are involved. Of course, this leaves out folks who have upper GI Crohn's involvement. About a fourth, we think, up to a fourth of patients will also have some upper GI involvement. And then a fourth can also present with perianal disease. I want to draw attention to this because this means 2/3 of patients probably have their ileum involved. And the small bowel has a different job than the colon. It doesn't just absorb water, it absorbs nutrients. So if it goes down, who's absorbing the nutrients? No one. So people can have malabsorption. They can present with profound weight loss. Respect to the family med docs out there. I do not work with children, but this is commonly a presenting symptom in children where they just fall off the growth curve. So it can happen in adults too, where they just all of a sudden start losing weight. And some of them are happy about it, but you have to remind them it's not good if you're just not absorbing nothing. Vitamin B12 is absorbed in the ileum, so it's a very common vitamin deficiency. Really, humans who aren't super, super strict vegans and are having some sort of animal protein in their life shouldn't have a dietary deficit of B12. So if they do, just wonder, hey, is it because you're not absorbing it? And then in terms of focal pain, the right lower quadrant classically is where the ileum and the cecum sit. So many people will have focal pain there. Not all, but many. That's really, I think the take home of this slide is small bowel does a lot. When it's involved, new things can happen. I'll leave us an end note that upper GI inflammation is rare, but not unheard of. So if you've got a young person who like has rip roaring like heartburn, has like insane vomiting just out of the blue, and you can't figure out an answer for it, if they have horrible odynophagia and are being told that they have it's not thrush, they're not immunocompromised otherwise, remember that massive ulcers can be caused in any part of the GI tract from Crohn's. And it might be worth putting on your differential. Okay, we go to the other side of the body. Perianal disease is a really, really hard disease. Crohn's disease, in addition to affecting the mucosal surfaces of the GI tract, can present with abnormal connections from the rectum to the skin of the perianal area, which, as you can imagine, is not something that you really will not want ever in your life, but particularly young people. It's something that can be very embarrassing and is something that sometimes people don't want to talk about. Um, my take home for perianal disease is ask about the anus and ask about the perianal area. People will come in, they say, I have pain when I poop. I have pain when I pass bowel movements. And we will assume that they're talking about their abdomen. But sometimes when you dig further, they will say, no, it hurts when it like comes out. Like it hurts when it's passing through my anal canal. And that should make you think, is there an abscess back there? Are they having a hard time sitting down? Is there a fissure back there? Why is there a really bad fissure back there? So ask about the anal canal and don't be afraid to use the language that patients are using um, to help them feel more comfortable talking about this area. Second take home from perianal disease is anal fissures. We usually see them if they're not complicated, they'll be at the 6 o'clock or 12 o'clock position, so anterior, posterior. But in Crohn's disease, actually, they can show up anywhere and they can be deep and they can be very painful. Um, they are really hard to see. These two pictures actually both have anal fissures in them, and I bet you, like, I'm like 6 inches away from my screen, and the one on the left that's down at the 6 o'clock position, that's actually pretty subtle, and there are 3 hands pulling the perianal skin apart for us in this picture. So they're hard to see. Um, Exams are important. Try to get people to relax as much as possible. It's going to be hard. They hurt. They don't want anything near there. But if you can get them to relax, don't. A diagnosis is going to serve them very well. Try to see as much as you can. Um, and then over to the right, in addition to the anal fissure, there's just an illustration of a pretty big fistulous opening. So this this out spot there, that is actually an abnormal connection that burrows through the patient's pelvic floor into their rectum and will ooze or leak fecal matter. That's a perianal fistula. Fistulas in and of themselves can just show up as like tender bumps and like fecal incontinence where they're like, I'm draining poop. And you're like, tell me more. And they're like, I don't know, it just shows up. Maybe it's because it's coming out of a hole that they don't have a sphincter for. Um, so that's a fistula, a perianal fistula. And then what happens when the fistula doesn't have an exit to drain from anymore? It gets kind of blown up like a balloon and it turns into an abscess. Um, Abscesses down here can put people into septic shock pretty fast. So um, don't be afraid to send them to the emergency room. And don't be afraid if they have recurrent abscesses to be like, hey, what's going on here? Why is it coming back? Is this Crohn's? Okay, taking a break from inflammation, Crohn's can actually do things other than inflammation in different areas. It can create strictures. And this is where it's our job to be fancy plumbers. Basically, GI system, open pipe system, it clogged. Patient feel bad. Um, the symptoms are going to be like small bowel obstructions, but light, or people will have them come and go. It'll be partial obstruction, and then it will clear on its own. Or sometimes, you know, if you think about a blockage, what's going to make the blockage worse? Putting foods in that can't pass. So like tough foods, fibrous foods, roughage, kale, steak, sometimes people, you'll ask them, you're like, oh, do you have pain? They're like, oh, no. And you're like, wait a second, but did you stop eating anything because it caused you intractable pain? They're like, oh, yeah. I haven't eaten raw vegetables in 5 years. They're like, okay. Well, we should think about that. Um, Really, it's a narrowed pipe. What's gonna, uh, what's gonna clog it? And then what's gonna happen once it's clogged? They're gonna get distended. They're gonna get nauseous. Sometimes they'll be vomiting because literally nothing will go down. And to counter to challenge our illness script of pain and diarrhea for Crohn's, people will not be pooping during this time because there will not be anything coming out through the blockage. So remember, inflammatory symptoms are what our minds go to, but if something doesn't smell right and it sounds like a pipe's getting stuck, remember that obstructive symptoms can also um, be a presenting sign of Crohn's disease. Okay, and then fistulas are another terrifying, fascinating sequela of Crohn's disease. So um, we talked about perianal fistulas. A fistula, by definition, is an abnormal connection between two lumens. So it's basically like it's like the shortcut nobody wanted. It can happen because those two PVC pipes that are on fire, if if the PVC pipe on fire sticks to another place and then it doesn't heal correctly, it can actually create a tunnel to a new location. It's basically like a perforation, but instead of perforating into the middle of the abdomen, it perforates into another structure and then just contains itself. So it's rare that these are presenting findings, but the reason I put it on your radar is because not a lot of things cause fistulas, like cancer, ischemia, Crohn's disease cause fistulas. So if someone's got a fistula, it's narrowed your diagnosis, and that can help them faster. This diagram just illustrates the fact that fistulas can form between the intestine and literally any neighbor. So neighbors being the skin, so intestine to skin. Enterocutaneous fistulas are horribly morbid. People can have stool leaking out of their skin uncontrollably. Enteroenteric fistulas, so healthy nearby gut smashes into proximal gut. Well, what happens if, the beginning of the road just dumps into the end of the road? It bypasses all of the intestine that's supposed to be absorbing nutrients. So people can have effectively short gut or massive weight loss with this. Colovesicular, I will highlight because recurrent UTIs can sometimes masquerade as this or hide this. Um, if the colon sticks to the bladder, it pours poop and bacteria into the bladder, and that creates infection. Don't be afraid to ask people, do you pass cloudy urine? Does it look like stool? Do you pass air bubbles in your urine? Because that can tip you off. And then the last thing I'll mention is holovaginal fistulas they do have an extra differential because of childbirth. Um, but if someone is leaking stool uncontrollably, remember, is it coming from the vagina? And is it coming because there's a fistula there? The reason I bring this up is because, yes, they're rare, but one, they can help very quickly with a differential. And two, if someone presents like this, they need both GI and colorectal surgery because we don't have medicines to fix these, and they deserve to have those referrals started right off the bat. Okay. So we talked about all the things that inflammatory bowel disease could do to the bowels. But I want to remind us that there are some extraintestinal manifestations that are actually fairly common in people with inflammatory bowel disease. They are inflammatory processes in the body that are linked to inflammatory bowel disease, but not in the intestine. Joints, um, we have all met a patient with a pan-positive review of systems who will tell you that every joint in their body hurts in every way. I like to mix in like joint qualifying questions to help figure out if it's really inflammatory pain. So like, oh, is it worse in the morning, like you're stiff, or is it like really bad at the end of the day when you've been moving around a lot? They don't know which one is the one that fits your illness script, so you're more likely to get something that maybe is a little bit more helpful to you. But inflammatory pain, classically, stiffness better with movement, can happen both peripherally in these patients and also uh, axially, so like back, hips. Um, Skin rashes. I think my take home for skin rashes is that they don't nobody would call these rashes, colloquially. We've got erythema nodosum, which is the big picture in the middle. Oh my gosh, I saw a lady with this today. It looks like a horrible bruise. Like it looks like a raised lump bump that is often red, though can show up different on melanated skin, and is tender, like they really hurt. People think they're bruises sometimes. They're classically on their shins, on their knees, on uh, um ask about rashes, but also say any painful bumps because some people may be like, oh yeah. Second extraintestinal manifestation linked to IBD, pyoderma gangrenosum. No one's gonna cause this big non-healing ulcer or rash, but it qualifies as a rash. So I say, hey, have you had any, big painful non-healing wounds? And people say no, but if they do, they will tell you. I left at the bottom things that are, I think, less helpful for the original, for the first intake: mouth ulcers, uveitis, fatigue, fever. They're just very non-specific, or very rare. So they exist, but might not be super helpful for you. Okay. Last thing I want to talk about in terms of presentations. Um, there are two emergency room indications we have to talk about. One relates to ulcerative colitis in the yellow. Acute severe ulcerative colitis is basically like septic shock that has been generated by ulcerative colitis inflammation. Um, it's got a 1% mortality, which, yeah, 1% sounds low, but like you take 100 college students with ulcerative colitis and you give them, and one of them dies, like that's huge. That's awful. So, in like 10-15% of patients, this can be the initial presentation. So, if they have 6 bloody bowel movements in a 24-hour period, remember, nighttime counts with systemic toxicity, tachycardic, temperatures, hemoglobin under 10, elevated ESR CRP. That's somebody who, you know, if you've got a diagnosis and they're getting better, and then trust your clinical intuition, but do not be afraid to get them to the emergency room, um, and have them have closer monitoring. Um, Second, Crohn's disease with abscess. So Crohn's disease can make abscesses perianally, intra-abdominally. If they have fever, if they've got pain, if something isn't right, remember they could be hiding an abscess that's about to make them real sick. So if you and your community have fast, easy access to contrasted CTs, amazing. If you don't, sometimes the emergency room is safer for them. Okay, a summary of that really meaty portion. Ulcerative colitis presentation is often classic, bleeding from the bottom. Diarrhea is common, but you can also get constipation if just the rectum's involved. Crohn's disease, way more options. Inflammatory symptoms of pain, diarrhea, weight loss. Obstruction, just think about a blocked pipe. And then those more rare but more Crohn specific things: fistulas, abscesses, perianal disease. Remember to ask about extraintestinal manifestations, joints, the stiffness that gets better throughout the day, and the painful nodules for erythema nodosum. And then also remember there are some special emergencies that uh, deserve escalated care for. Okay, this is the portion that I think makes our head spin. Inflammatory bowel disease diagnosis is clinical, which is like cool because we'll have jobs and we can think through this and we can help people. But it's frustrating because there's no one test that's going to say, bam, you have inflammatory bowel disease, locked in. Instead, I think of it like a puzzle. Like you're basically just collecting puzzle pieces and then you have to squint at the puzzle and say, does it look like inflammatory bowel disease or does it look like something else? 3 very important parts of the puzzle are histology, so getting tissue sample; endoscopic appearance, that's why you call GI; and imaging can be a little bit more nuanced parts of the puzzle that we'll talk through. At the core, Inflammatory bowel disease is, as we talked about way back in the beginning, it is chronic GI inflammation with no enemy, so with no infection. And that's really what all of these puzzle pieces are trying to paint a picture of for us. So initial workup. One of the most important thing to start with when somebody presents and it smells like GI inflammation is the inflammation actually fighting an infection and therefore appropriate? So infectious studies key. When you're testing for C. diff, which anytime someone's having diarrhea, it would be appropriate to do that. PCR alone is not helpful. PCR will tell you that the C. diff bacteria is there, but it will not tell you whether it's a toxigenic strain that's actually causing problems. A lot of people are colonized with C. diff. PCR alone, if you just get the PCR, it can often be a red herring. So if the PCR is positive, make sure that's reflexing to EIA, so an immunoassay. That's going to actually test for the protein of the toxin that problematic C. diff will be generating. That's just C. diff is, it has been confusing us for the ages, but PCR plus EIA or toxin immunoassay. Second thing, stool culture is always helpful to round things out. Very important to just, even if you don't think that there's an obvious exposure, take it off the table, because way better to have an infection than to have a lifelong incurable disease. If they have terminal ileitis, consider asking for Yersinia, because that specifically causes ileitis, and it's not always a default stool culture test. Ovum parasite testing, again, even if it's very unlikely, let's just take it off the table. Better than having an incurable disease. Remember, other things can cause infection in the rectum, including sexually transmitted infections. So remember this for your patients who have proctitis. Self-swabbing is powerful, gonorrhea, chlamydia. And remember to always rule out HIV, because HIV can do everything. So infectious studies, they're cooking. What if, like, you're not really sure if it's inflammation? It's kind of, they've got symptoms, but maybe you're thinking, oh, symptoms, IBS. When you're checking for, trying to figure out whether inflammation is there, please send a fecal calprotectin. This is, I polled my IBD colleagues. I was like, what's your wish list? They're like, fecal calprotectin. Fecal leukocytes are common, but they are not as quantifiable, and we can't trend them 1 to 5 years down the line when somebody ends up having inflammatory bowel disease and we want to know whether it's under control. Fecal calprotectin is really, really helpful for us. So if you're going to pick an inflammatory stool marker, pick a fecal calprotectin. Next point, NSAIDs. If someone's taking NSAIDs, it's basically like trying to stare at their diagnostic puzzle piece through like bubble wrap. It confuses everything. It can cause acute inflammation. It can cause chronic inflammation. It can cause colonoscopic changes. It can cause histologic changes. If they're using NSAIDs frequently, it completely clouds the IBD diagnosis, and they need to be counseled to come off of them before we make any assumptions about their immune system. And the last thing is, as we think about that second age peak, remember older patients can have ischemia that acts like, that causes inflammation. So just remember, think about their blood vessels. Do we need to think about mesenteric ischemia, that kind of thing. My beautiful giant circles with dashes through them, things that are less, okay, fecal leukocytes, meh. If I can get fecal calprotectin, I'll pick that. And then, genetic testing and serologic markers. We have dreams, right? But they're not ready for prime time. They are not going to be helpful. In fact, they're probably just going to cause stress and confusion. So don't order them. And then the last thing I will mention as we're thinking about this initial workup, and how fast to do what test to get, how fast. If someone has hematochezia, especially if they're young, remember about the rise of early onset colon cancer. I know that Dr. Dziwas recently talked to you guys about colon cancer. Colon cancer can mimic inflammatory bowel disease. Hematochezia keep things broad, don't necessarily anchor, and just remember we're being humbled by the early onset colon cancer. This was a question that Dr. Moore passed along to me, which is, just the general question of when to refer to GI. And I'm worried that I'm going to attempt to be helpful, but really be not helpful in the sense of there's not a magic time. The higher degree of your suspicion, I think it's the earlier to refer is appropriate. Um, and I want to highlight just in terms of referring effectively, some nuances. So different GI practices do it differently. Sometimes when you go for a procedure, you're in with that GI group forever. They're going to follow you. You're their patient now. The procedure that people need for diagnosis of inflammatory bowel disease is a colonoscopy, which will include terminal ileum intubation, or like turn the corner and sticking the camera in the ileum. Some GI groups, when you get in for this procedure, if there's something wrong, they'll take you on as a patient. You're good to go. But not all practices work like that, and Duke GI is different. So some practices, procedures, you meet the doc just for the procedure. But then to have a continuity relationship, people need to be seen in clinic, which sometimes is a separate referral process. So just be aware that when you refer, if someone's initially been referred for a procedure and and there's a new diagnosis cooking, a continuity provider needs to be secured. This slide acknowledges that I'm minimally helpful. You know your local practice patterns best. You're most familiar with referral wait times, and then how GI groups do scheduling. So again, there's not a magic time frame. If you're worried, refer early. If you are less worried and have next steps to do, don't feel pressured to refer early if you know that you can get someone in when and if you need it. I left this little note at the bottom because I think it's something that is really the mantle that we need to take up as GI doctors, but you can help us. So early IBD treatment matters so much. People with inflammatory bowel disease used to get diagnosed and then just languish with like no options for decades and decades and just have surgery after surgery and steroid after steroid. We know that if we get people diagnosed and treated for inflammatory bowel disease within, we think like it's not a long time, like 1 to 2 years of their symptom onset, we can actually change the natural history. Like we can keep it from turning into as big of a massive fire as it otherwise would have. But this means that the college student who sat on their symptoms for 6 months, then waited for summer break, then came to see you, then didn't submit their stool samples, and you finally get them to a GI doctor like a year and a half after the symptoms start. Those are the people who, the timeline starts to narrow. So uh, remember that we can make a difference, and we can make a difference by reminding people um, to do the workup in a timely manner. Okay. Last thing I want to mention with diagnosis, imaging is it's nuanced enough to feel annoying. So importantly, first and foremost, it can't replace colonoscopy. Everyone needs a colonoscopy if inflammatory bowel disease needs to be taken off the table. You can't take it off the table just with imaging. But because imaging can miss things. But if you suspect Crohn's disease, especially obstructive symptoms, imaging is important because it looks at the small bowel. We only see, maybe if we're lucky, like 5 to 10 centimeters of the small intestine, the end of the small intestine on colonoscopy. So there could be something upstream that we completely miss. Colonoscopy looks normal. So small bowel imaging is a perk of this. And then if you suspect an abscess, um, imaging is going to imaging is key. Like you don't want the colonoscope going outside of the colon to find the abscess. That's called the perforation. So imaging helps. Ordering tips. Again, not an exhaustive list, but think IV contrast inflammation. If they've got okay kidneys, please give them IV contrast. It really helps us figure out what is actually inflammation and what is just a squeezing bowel. Second, oral contrast, confusing. I get confused. Give clinical context to your radiologist and they will help guide you. I say like, enterography is a helpful word to put in because it just means that the clinical context is, or you can say like, please assess lumen carefully, or like, you know, I've been told that oral contrast is helpful. Pick one for me, please. Or just say I'm thinking about IBD. CT and MR are both good options, whatever you have access to. For picking up on inflammation for new diagnosis, you don't need to, one is not superior necessarily to the other. This is a picture showing a beautiful blocked pipe with arrow signs to tell us where to look, but you can see all the fluid. That is contrast, oral contrast. So again, how oral contrast helps getting backed up behind the blockage. This slide is simply to tell you that endoscopy and histology are your GI provider's job. It is not your job to interpret the images or the pathology. In fact, histology or pathology can sometimes not be straightforward. And that is a conversation that a GI doctor can have with a pathologist to help understand what does this puzzle piece kind of look like. They may reach out to you to help fit things together, but don't feel pressured to interpret by yourself, and don't feel pressured to give patients a clean answer, because sometimes there's uncertainty or there's nuance, and getting a flip-flop answer can be stressful for someone, and you shouldn't feel pressured to give the bottom line if it deserves more discussion. Most people won't need upper endoscopies, the exception being those with the upper symptoms we talked about. And then this is just a reminder, if you're kind of tracking into the territory of like, do we need a video capsule endoscopy, or like, how about deep enteroscopy? Like, that's something that deserves a GI brain on board with, because they have their own risk benefits. Okay, diagnosis. Rule out infection. Please get fecal calprotectin. We love it. Make sure they're not using 20 million milligrams of ibuprofen. Ignore the genetics and serology tests for now. They are not ready for prime time. Colonoscopy is key for diagnosis. You can't replace it with imaging. And if you're thinking small bowel, reach for imaging, inflammation, IV contrast, helpful. I know we're up against 8 o'clock right now. I have a couple of brief slides on management, but I wanted to check in with Vinay and Dr. Moore. Should we break for questions?
I think you can go ahead with your management and wrap it up. And Vinay, do we have questions pending?
No, we don't have any questions in the chat,
Okay.
so she should be good.
Yeah, Dr. Wong, I'll go ahead. Just clip.
Okay, great. So in terms of management, there are more questions that any human has time in clinic for. It's hard because we want to be there for people, but uh, our visits aren't long enough. So the Crohn's and Colitis Foundation is an awesome website designed for patients and their families, but they work closely with providers and research. They are a non-sketchy corner of the internet. So this is a screenshot of their website map, all the different things that they address. This is their website. And this is where, when people open with big, heavy questions like, I don't want to have a bag, or like, am I going to be on medications forever? A gentle nudge towards this resource can really empower people to learn more about what's happening to them in a way that's accessible and on their own time. I figured that talking about pain and as needed meds might be helpful. In inflammatory bowel disease, it is beautiful but stressful. Pain management is IBD management. So the way that we get inflammatory bowel disease pain under control is we make a diagnosis, we use IBD specific therapies, and the inflammation goes down and they get symptom relief. Um, a lot of our other analgesics cause problems. So uh, really acetaminophen is the go-to. If they've got a healthy liver, up to 4,000 milligrams daily of acetaminophen, people often underdose. They say it's not working because they're only taking, 250 milligrams. But 4,000 milligrams a day, you can decrease it down to 3,000 milligrams if there's someone who uses alcohol occasionally, just so that you make sure you're away from the liver toxicity limit. But acetaminophen feels wimpy, but is the go-to. Um, NSAIDs we classically avoid because there are some old studies saying that they increase risk of inflammatory bowel disease inflammation. So largely I have people stay away from them as much as they can. Um, and then some medications are actually dangerous in active inflammation from inflammatory bowel disease. So we're talking toxic megacolon is when there's this like horrible ileus in an inflamed colon and it's a surgical emergency. That is increased risk by opioids. Um, Loperamide and dicyclamine are super commonly used for diarrhea and cramping related bowel movement pain. But if somebody has hematochezia or super heavy inflammatory burden, they can also increase risk of ileus and perforation. So if inflammatory bowel disease is the active working diagnosis, or really, really high up there on the differential, just counsel people. And then steroids sometimes become the primary care wheelhouse, especially in that limbo between you're pretty sure there's a diagnosis, but they don't have not yet met a GI doctor. I want to emphasize, please don't start them before the inflammatory bowel disease diagnosis is established because they can really mess with our tests and make it so that someone who, is the inflammation gone because the steroids or because it wasn't there, we don't end up knowing. Pros, cons, just as you're familiar with for other pathologies, just make sure to think about cons within the context of each individual patient. And then the last thing I'll mention is always rule out infection first, because tamping down the immune system is never the answer when there's an infection. And then second thing is inflammatory bowel disease does not like to have the rug pulled out from under it. It likes a taper. So purposefully smaller off to the side. I've got just an example of how I would typically taper somebody on steroids for active inflammatory bowel disease inflammation. Think like down by 5 or 10 milligrams per week until they're off. And to reach out to you if they have symptoms that get worse as they taper down. And I think a good rule of thumb is if you're at the point where you're starting steroids with a patient, they need to meet a GI doctor before their steroid taper is done, so that they have a landing pad. Oh, I lied. Not the last thing. Please help our patients with smoking cessation. It is essential for Crohn's disease patients. And we lean on primary care so heavily for this and continue reinforcing your motivational interviewing in our work. Okay, so that's it for management. Remember, Crohn's and Colitis Foundation website, very helpful. Pain control, very interlinked with inflammation therapy. Don't use steroids before you've got a diagnosis, and if you do use them, rule out infection and remember to taper.
Hey,
And these are some core references for y'all. I'm happy to take questions.
yeah, Dr. Wong, we have some questions in the chat. And let me just mention that if anyone on the call wants a copy of the slides, if you will, we will put the recording of this up on the Sovah external website first of the week. But if you want slides, if you'll email me or Vinay, we'll get those out to you. Vinay, can you start sharing the comments or calling on people that want to do it verbally?
Sure, we'll have the first question is, in terms of monitoring today, are providers targeting histolic remission, transmural healing as our treatment goal, or is endoscopic remission sufficient?
That is a very nuanced question, and something that's on the mind of the entire GI community. Presently, endoscopic remission is our our goal by guidelines. So it is our goal that we have established data that reaching this goal is clinically meaningful. In the sense that when you reach endoscopic remission, there's a clear improvement in decreased colon cancer risk, decreased flare risk, decreased hospitalization, decreased surgery, um, uh, and decreased progression of disease. So endoscopic remission is currently the most aggressive control or the most advanced goal that we seek for our patients, in the sense that we feel confident that achieving that is going to actually translate into a difference for our patients. But histologic remission is certainly something of interest. And transmural healing, especially with a lot of rising interest in the role of ultrasound in inflammatory bowel disease, for our Crohn's patients, that full transmural healing is something that is interestingly being used more and more as an endpoint or secondary endpoint in clinical trials. So while we currently don't have guideline level data to say these are clinically significant milestones that we should be pursuing, there's active work being done to try to understand whether we need to expand our remission goals to those points.
Okay, Dr. Fine, can you ask your question, please?
Yes, I mean, the question is, after a patient has failed 2 biologics, let's say a TNF and one other, I mean, what is your threshold for dual therapy, and do you have a favorite dual therapy?
Mm, that's a great question. I got the chat pulled up too. I see ileal disease mentioned. Um, and Dr. Fine, to help me be most helpful, remind me, are you a GI physician, a surgeon?
He's a
No, I'm a
gastroenterologist.
gastroenterologist.
Got it. I was wondering with your question, I was like, oh, I wonder if you're thinking about it sounds like a specific case is on your mind. Um, so uh, there are a lot of nuances to it in the sense of um, ileal disease, whether there's active inflammation or whether it is primarily stricture with the absence of inflammation. Um, if somebody has intractable obstructive symptoms from non-inflammatory obstruction, then they're declaring themselves as needing surgery, because we're not going to be able to reverse it with medications, obviously. If they have active inflammation in their ileum, with uh, obstructive symptoms like upstream dilation, um, surgery, I think after failure of 2 biologics, it would be absolutely reasonable to put it on the table, especially if they've got relatively short segment disease, or they have contraindications to additional mechanisms of biologics. In terms of thinking about our you know medication toolbox and what could be done for ileal intractable inflammatory ileal disease, um, I think that unfortunately, I mean, Entyvio is off the table. It's wonderful in colonic disease. It's really not helpful in small bowel disease, which leaves us with anti-TNFs, JAK inhibitors, and anti-IL-23 medications. We have had data that, with the um, between the head-to-head with an IL-23, 1223 and an IL-23, that IL-23s seem to have more robust endoscopic response. So if one of their failures was an anti-IL-1223 and they had a partial response, you could consider changing them to an IL-23. But I would say before moving to dual therapy, because I think all three of those classes can have some benefit in small intestine disease, it would be worth trying the final monotherapy group before doing a dual therapy.
Do you have a favorite dual therapy, or have you been studying dual therapy?
So I sometimes my hands are tied by the time they get to me because if they've been on an anti-TNF before, so uh, it's it's helpful to combine a gut-specific therapy with a non-gut specific therapy.
Mm.
So, for example, an anti-TNF with an IL-23 or an anti-TNF with Entyvio, um, or sorry, vedolizumab, and that or like a JAK inhibitor with an IL-23. Um, Oftentimes when people come to me, they have failed an anti-TNF and have antibodies to them. So it's not an option to combine an anti-TNF with something. Um, but so I'd say most of my patients who are on dual therapy, who's not a ton of them, but I'd say the most common combination that I've encountered has been in IL-23 with a JAK inhibitor.
Mhm. Okay.
Are am I using those in people who have exceptionally abnormal immune systems and I'm worried are going to head to surgery one day? Yes. But that's the combination that I've had the most experience with.
Right. Thank you.
Thanks, Dr. Pine. We have other questions, Benay?
We do. Sally McIntosh, can you ask your question, please? And if Sally is not on, Lydia Shelton.
Yes, Dr. Wong. My name is Lydia Shelton, and I was wondering if you've had any patients that have ulcerative colitis and they've had to go on INH and rifapentine for LTBI. How did they fare?
Um, I have had so um I'm just like making sure that I'm pulling up the right patients in my brain. I have had a number of patients who have been treated for latent TB. Some of them I met later on in their disease course, so they were treated for latent TB years ago, and they are doing well on biologic or advanced therapy now. I have one interesting patient who actually there was a lot of song and dance about whether they had latent TB or whether they had TB with colonic involvement. And they actually underwent full therapy for latent tuberculosis, were cleared by infectious disease, and we've decided that now it's just our turn to treat their inflammatory bowel disease. But I haven't had, have not yet, knock on something wooden, someone have reactivated tuberculosis after being treated for latent TB while on an advanced therapy.
Okay, but how do they tolerate the medication with all this inflammation in the bowel?
In
Because
terms
the
of the
medication's pretty rough on the
I
bowel.
understand. I to be honest, my count of patients who I've witnessed go through the latent TB treatment didn't have any issues, but that's like an N of maybe two.
Okay.
Of the people who have had latent TB treatment in the past 5 years, who I've talked to them about, they haven't had issues with it.
Okay, great. Thank you.
So I guess we can tune in with Dr. Turner in 2 weeks and we can ask him. He's the TB expert. We can
Yes, there we go.
same question. Benay, Dr. McIntosh said she didn't have audio, so can you read her question? I haven't looked at it.
Let me go back up to it. She said, excellent presentation, Dr. Wong. What needs to change in our approach so patients feel heard beyond just physical flare-ups?
Um, oh, Dr. McIntosh, I wish I could clarify with you a little more by because it's a great point. and there's many ways that people can feel unheard, and to need their suffering witnessed by their providers. Um, I think that in terms of having patients feel heard, um, I I think I'm struggling because I'd like to know what challenges you've encountered. Without being able to do that though, something that I will say is I have a lot of patients with inflammatory bowel disease who, in addition to physical symptoms, also have a lot of psychosocial stressors and also have a lot of mental health comorbidities. And um, something that I uh, really try to do with my patients that I think is helpful for many of them is actually talk to them about how there's an increased risk of anxiety and depression in patients who have ulcerative colitis and Crohn's disease, regardless of how bad their symptoms are. It is incredibly normalizing and I think affirming to have people know that their mind, body, spirit are going through stressors and are vulnerable to comorbidities, that it's not that they're doing something wrong. It's not that they're being ungrateful. It's that they're they're they are experiencing illness that impacts many parts of their life. So I like to remind them that just because something's going wrong doesn't mean they're doing anything wrong, and that uh, opening up about symptoms they're having on a mental health side of things uh, is not weakness or ingratitude. It's we don't understand why. We wish we did, but their biology is a little different, and all we can do is listen to them and figure out what other tools need to go on board.
And yet, Vinay, any other questions?
Sally McIntosh, she just responded and said many are impacted by the social deterrence of health.
Mm-hmm. Mm-hmm. Um, so it's so true. Um, I'd say something that if you and your practice have the bandwidth for, um, trying to advocate for them in as many spheres as possible, um, uh, in terms of, you know, with my young patients, I'm like, not even my young patients, everyone. I'm like, how's work? What do you do for work? How's work treating you? Are they being good to you? Are they giving you the time you need for your infusions? Are they giving you the time you need for your clinic visits? Um, oh, you drive, you know, if you look into a parking permit for urgency, I'd be happy to sign that. I don't have the ability to fill it out, but if you bring it to me, I'm happy to sign it. If uh you want to look into Ensure drinks because nutrition is such a distressing part for you and Ensure is so important, like I am happy to sign that medical equipment form for you. I acknowledge that it is not always easy to advocate. It can be very time consuming to do it in these certain ways. But if you have patients who are grasping at straws and they're willing to put in a little legwork or partner with a social worker to help get you the forms, we can advocate in some pretty creative ways.
Vinay, do we have any others in the chat?
No, that's all that we have.
Dr. Wong, I'll ask
uh,
you one thing, and you might want to tell the group, we have a lot of folks on the call, our residents and so forth. Maybe everyone knows this, but can you explain very briefly what fecal calprotectin is and how
oh,
one
yes.
checks for it?
So fecal calprotectin is a protein that is produced during colonic inflammation. So just like ALT or AST is spilled by hepatocytes when the liver gets injured, when the colon is injured, fecal calprotectin is a protein byproduct of that. Um, it doesn't absorb into the systemic circulation, so you can't test someone's blood for it, but it leaves the body in the stool. So if someone is having active inflammation in their colon, some but not all, many people will shed a protein called fecal calprotectin, and then you can just measure it in the stool. It can be really, really nice for trending inflammation, because if someone had a fecal calprotectin, say like stone cold normal is under 50, if they have a fecal calprotectin of like 400 when they're diagnosed, and you start them on a medication and you confirm that it drops down to 20, when in 2 years they, are really stressed out at their job and they have symptoms of IBS syndrome or symptoms, not damage, then you can test the fecal calprotectin and be like, oh, wait, is this your colitis that's flaring, or is this something non-damage related that's going on? And it is a little more quantitative than some of the other inflammatory markers that we have in the stool.
Sounds right. So it's analogous to BNP for heart failure, or a C-reactive protein for coronary heart disease in a broad sense. So.
In a broad sense, I will say, don't be alarmed or deterred if someone has a normal fecal protectin, but all the other puzzle pieces look like inflammatory bowel disease. There are some people who, unlike like troponins that are universal, there are some people who just don't shed a lot of fecal calprotectin, and they'll have stone cold normal values with raging inflammation. But yes, if they are someone who mounts a fecal calprotectin, it's really nice to trend.
I think we got one last, thank you. I think we got one last question. Dr. Pradhan, you want to come on and you got your question, and then we'll wrap.
Yeah. Dr. Wong, it's a wonderful presentation. Two-part question. One is about the fecal calprotectin. Do you think that will go high in the diverticulitis? If sigmoid diverticulitis. And the second part is in the early work of inflammatory bowel disease. So you suggest like upper GI small bowel follow through, that will be the beginning, and then plus a historical presentation. Will that be the starting point? Thank you.
Thank you so much for bringing up the diverticulitis, because my brain flashed by it. But fecal calprotectin is just inflammation and is non-specific to what causes the inflammation. So if you have E. coli colitis from eating a bad hamburger, you'll have a high fecal calprotectin. If you have diverticulitis, you'll have a high fecal calprotectin. If you have Crohn's, you'll have a high fecal calprotectin. If you have ulcerative colitis, you'll have high fecal calprotectin. So it just simply tells you there's inflammation in the colon. It doesn't tell you why the inflammation's there. Ischemic colitis can have a high fecal calprotectin. So it's more helpful in saying inflammation, no inflammation. It doesn't help at all with the type of inflammation. In terms of small bowel follow-throughs, I've heard from several people tell me like the art of X-ray is being lost with cross-sectional imaging. And I admit that I was born into this generation of dying plain film scans. I much more commonly see cross-sectional imaging than I do small bowel follow-throughs. I think small bowel follow-through can be helpful if there's not access to cross-sectional imaging and you're worried about obstruction. But because so much of inflammatory bowel disease only affects distal small bowel or colon, it doesn't do a great job of, it's not a good rule out test.
Low sensitivity. Yeah.
Thank you.
Thanks, Dr. Pradhan. Nothing else in the chat, Vinay?
No, that's it.
Okay.
I think I saw one from Dr. Honia. Correct. I don't send Pianka or Aska.
Sorry, what was that?
Oh, I think Dr. Honia asked about Pianka and Aska.
Bob, is that Dr. Nea? You have a question, Dr. Nea, Bob?
Yeah, I saw you said no serologic test. So in an early workup, someone presenting early on, you don't bother getting those two serologic tests just to help distinguish between UC or Crohn's early on?
No, we get actually a lot of information on endoscopy regarding Crohn's versus ulcerative
Yeah.
colitis.
Yeah.
And those markers have
Mhm.
unfortunately
Right.
never helped me
Okay.
figure out someone's
Right. Yeah. I meant before
underlying pathology. Yeah.
colonoscopy. Before colonoscopy, they just presented acutely ill. First time, never diagnosed. Because how is it? I mean, it is nonspecific, but it's no more nonspecific than the calprotectin, it sounds like.
I would argue that because they're serologic tests, they can be elevated in a variety of autoimmune conditions
Ah, okay.
and are less helpful in terms of an IBD diagnosis.
Gotcha.
Yeah.
Okay, thank you.
Yes, absolutely.
Okay, any other questions? Last call. Okay, well, thanks so much. Dr. Wong, you did a great job. I certainly appreciate everyone being here. We had a tremendous turnout for this. Really, really good. Running overtime is always great when the conversation's so good. We hope you will be back with us in 2 weeks. I think it's Thursday, August 13th. I may be misquoting the date, but Dr. Nick Turner from Duke Infectious Disease will talk about tuberculosis, the white plague, as one of our local infectious disease docs calls it. So thanks for being here. Hope everyone has a great evening. It's cooled off a little bit. The rain's passed through. It'll be a nice few days. So thanks for being here. Take care and good night. Bye-bye.